Some of the consequences of malocclusion is that it affects the teeth. It affects the gums because it's a secondary contributor to periodontal disease, because you have the bacteria, and then you have the occlusion, which then causes the irritation. It then makes the bone go away. You're losing periodontal support. You guys see this all the time where it's intact. It's loss of the supportive periodontium, but it's not in the presence of disease. They could be stage 3 and not have disease, meaning like biofilm, absence of biofilm and bleeding because of occlusion. But look here on the x-rays, when you're looking at them and you're staging and grading, then you can see actually where the radiographic bone levels are. Jaw joints. We know also that clenching, grinding, malocclusion causes popping, clicking. It causes ear aches, headaches. People can't eat, they can't function, they can't sleep. And that we're not even talking about airway issues yet. So with the scan on the lower left-hand side, this is a person who has overbite, where the red on the occlusogram is showing us the heavier points of pressure. And you can see on the lingual of these anterior maxillary incisors that they are chewing almost at the gum line there because of their deep bite. And of course, you can see the narrow arch as well. So it also has effect on the muscles and more costly treatment. So a lot of times people will say to me, Kelly, this isn't hurting the patient. Well, usually periodontal disease isn't either. Many times it's not, but we must tell people what we see, because without the information, they cannot make decisions. So we have to tell them about the potential consequences of what comes next if it continues down this road. We are taking in these medical history forms. We're asking all the questions. We're asking about medications that we know cause xerostomia. We know that people are taking insulin or could be underdiagnosed for disease status. And we know also, too, that a lot of time it shows up in the mouth, right? That we are the first responders to conditions in the mouth. So also, when you're thinking about occlusion and you're thinking about how crowding, let's just say, for instance, crowding or, misalignment, let's just say that the teeth are lingual version. I saw rotations and lingual version today of teeth it was just a normal everyday day. And they trap more plaque and bacteria that make it more difficult for our patients to clean. And so do we not think that these areas are trapping bacteria that could make them more susceptible to other periodontal conditions, that they are also contributing to the disease status potentially of the periodontal disease? So for one, we have malocclusion that's weakening the PDL, right? And then you have the body going, no, I'm going to remove this bone. It's going to not crack off, but flick off pieces of enamel along the gum line. And then the gum and the bone are going to recede. And then you have exposed root. So now you got to care for that. And then it puts them at higher risk for periodontal disease. So then all of this goes into a cycle of how we care for our patients. All of these short-term solutions and treatments, yeah, they're treatments. They help the patient there. But those class 5 composites that are here with the abfractions, because we're not really treating the big picture, they're going to flick off. I say flick because that's a real technical word. Y'all who know me, I use very technical Kelly words sometimes, but it comes off. It will just, it bends. That's where the tooth will bend and it comes off. And then the patient has to end up spending money again to replace that class 5 composite.